Hello and welcome to SAM's MSSRP didactic session today. My name is Sarah O'Connor and I am one of the moderators. I wanted to share the IRB statement for the Office of Community Engagement and let you know that the themes that come from discussions, surveys, and group activities could be used in possible future publications or white papers. No direct quotes or identifiable information will be used for publication. Your participation is voluntary. You can ask us to not capture your input, and we will redact any comments you make at your request. My email is listed on the screen that will follow, and by attending, your consent is implied unless otherwise advised.
My name is Shamia Gary, and I am the Program Manager for the SAMS MSSRP program. First of all, I would like to congratulate all of our students for being selected to participate in our program, and I truly hope that your summer research is off to a great start. Welcome everyone to our first didactic session hosted by MCW Community Engagement. I hope that you enjoy the upcoming presentation. Before we begin, I do have a few quick announcements. All attendees will remain muted through the presentation. If you have questions for the presenters, please submit them through the Q&A section on your screen. There will be several points at which your questions will be addressed by our presenters. Also, there is a chat feature for general observation and for logistic purposes. At this time, we're going to have a welcome by our program director, Dr. Ramani Ramchandran.
Okay, good afternoon, everyone. This is obviously a very unprecedented time, and I don't need to tell you the difficult period that we're all going through and experiencing. And I couldn't really think of a more apt time than now to be engaged with this with the community. So this is a perfect didactic session for us to get off the ground. I promise we didn't plan it this way; it just happened. And so I'm going to welcome all of you and hope you have a really good summer experience. I'm going to introduce the speakers. We have three members of the community engagement team: Dr. Syed Ahmed, Dr. Brian Johnson, and Dr. Leslie Rafalo. And I'm going to tell you a little bit about each one of them and then let Dr. Ahmed take over. So I'm going to start with Dr. Brian Johnson and then move on to Dr. Rafalo and then to Dr. Ahmed. Dr. Brian Johnson is a family physician who is passionate about community engagement, global health, and health equity. He sees patients and teaches students and residents at the All Saints Family Care Center and St. Joseph Hospital. His community-engaged research projects include the Food Doctors and Milwaukee Street Medicine. He's excited to connect with students about community engagement this summer and supports the kinds of transformative community-engaged experiences he had as an MCW student. So he's a past alumni from MCW. I'll now talk a little bit about Dr. Rafalo. Dr. Leslie Rafalo is an associate professor in the Department of Family and Community Medicine. She's also the co-director of the Division of Medical Student Education in the department. In addition to teaching in the medical school and grad school, Dr. Rafalo is a community health researcher. She believes that the best research questions are ones that emerge from the community, and I completely agree with her. Her research has spanned topics such as food security, caregiver support, veteran health and wellness, and school-based health. All of her research applies community engagement principles to advance the health of Wisconsin communities throughout the state. So welcome, Dr. Rafalo and Dr. Johnson. And the last person that I want to introduce is Dr. Syed Ahmed. Last but not the least, as they say, he's the Associate Provost and Senior Associate Dean for Community Engagement, a professor within the Department of Family and Community Medicine, Director of Community Engagement Key Function of the CTSI Southeastern Wisconsin, and the Director of the MCW Community Engagement Corps. He serves as a catalyst for the development of intra and extra-institutional initiatives which advanced community engagement locally, nationally, and internationally. Dr. Ahmed focuses on three main areas within his work: developing partnerships with other departments, disciplines, and communities, developing programs benefiting communities, and conducting research based on the principles of community engagement process. So I welcome all three of you and Dr. Ahmed, and the floor is yours. Thank you again.
Thank you. Thanks, Dr. Ramachandran. I'm glad to at least hear you after a long time. And I'd like to start by thanking Sarah, Shamia, Kelsey, and my co-presenter, Dr. Johnston and Leslie Ruffalo. This may not be, I think it cannot be even a bit, in a way, better time or more appropriate time to talk about community engagement. As Dr. Ramachandran mentioned, with the COVID crisis affecting communities disproportionately, certain population, and the challenge of racism, which is blatant, as we saw a few weeks ago, some of the things we do is very much connected to making that trusting relationship with community. To do any kind of project doesn't mean you do a research project for the sake of research. Community engagement has never been research for research's sake. It is also an art and science, because we are in the medical school. We are all scientists or physicians and the other staff with a scientific background. So science is there. Art part is also critical because it is not a simple process how you relate to the community partners. I keep on bringing people to the idea that it is easier said than done. It is a very long, challenging process, and you have to get used to it, train yourself, learn from mistakes, and move on forward. So community engagement, I am going to tell you, is also new. And if I have some slides, I'll talk about a little bit about history. In medical colleges in America, community engagement has only history of about 30 years. And internationally, some other country has it longer than we do. Medical school, if you really want to know, didn't embrace community engagement till just a few years ago. A study done 15 years ago once asked who has community engagement mission or part of mission in the medical schools. It was less than 1%. Now, I think it has changed. It is more than 10%. Not enough, but I would tell you the overall, it is changing. People are learning community engagement very different way. And hopefully we'll discuss why community engagement. I also like to discuss what does it mean by community engagement, community engaged research, CBPR, which is community-based participatory research. What are the difference? We will not have enough time to go into details on every aspect, but I hope at the end you get the basic concept very clear. At least get some understanding of this concept, which is evolving throughout the country, nationally and internationally, in more than one way. I wish I could see all of you. That makes it easier for me to interact. So this is a very different format. So I'm guessing that you can see me well. And if you have a question, you can definitely put it in Q&A or chat. I'm going to ask you a question, and if you can answer. What do you think American standing, USA stands in terms of healthcare among all the developed countries, the top developed countries, which is about 15? I do not know what you're responding, and I do not know you really know the latest data, but I will tell you, this is 15th out of 15. At every level, America with the most advanced medical care, advanced quote-unquote health care, we are 15. Our infant mortality or maternal mortality or life longevity or burden of chronic disease, we are number one negatively on each factor. And this is the reason America is behind in major way in terms of health care, even health outcome. So many years ago, when people started looking into community engagement as a mode to address this issue, it was clear that if we want to change the community's health, we cannot do that by sitting in the hospital behind the four walls, beautiful buildings, or the clinics. Why? Because we came to know over time by research that your health outcome is dependent, only 20% of your health outcome is dependent on what happens in the hospital or your clinic. 80% of your health outcome is not connected to your hospital system. It is in the community where the people come from. Their food insecurity, homelessness, joblessness, or think about lack of mental health, or lack of insurance, lack of underinsurance, behavioral issue. If you started piling up all the other factors, we call it social determinants of health, that contributes to about 80% of your health outcome. So no wonder we know in America, and now with the COVID we learned, now with the crisis we are going through with the racism, blatant racism, it becomes very clear why we are behind, why we have a health disparity issue, why do we have health equity issue. So some of us have been working in this field for 30-some years. So this thing don't surprise us. I'm just glad that we are talking in a national and local platform to address it. This is the time to address it more. Let me briefly tell you what brought me into it, and I have not too much time to talk, but let me just tell you what got me involved into the community and community engagement. Close to 30 years ago, after getting my education in Houston, Texas, getting my residency, fellowship, master's, doctorate, all good stuff, I moved to a very poor, the poorest town in Ohio, about 1,500 folks. Their cardiovascular burden was significant, more than any other county, and it is actually one of the top counties in a bad way in the United States. So I came there as the second doctor to practice, and I had plenty of time in my hand, so I decided to develop a community-based program to address cardiovascular risk. I thought I have enough knowledge to do that. Then I got myself invited into a community forum to talk about my ideas. I was given about 10 minutes to talk. I finished it. Then I asked people to tell me what do they think about my idea. Are they interested? Not a single hand rose for about a minute. I was a little bit surprised. Then one young woman raised her hand, and I looked at her and I said, yes, what question is that? Her question was, where can I buy cheap diapers? So you have to think about a couple of reasons. I didn't know where the cheap diapers come from, or any diaper, that I'd have a kid. Plus, I was new in this town, and I did stop there for a few seconds. So this is, if I was face-to-face, I would ask you, what do you do in this situation? But I will tell what I did. What I did is, after I got my wits back, I looked around, because most of the audience were women. I asked, can anyone answer this young person's question? And at least 4 or 5 hands raised up, and they started helping her with the idea about what to get cheap diaper. And I'll tell you, that was the end of my cardiovascular risk reduction program in that county. I went back, and because I took a lot of my time developing that program on my own, then I felt like, what is the main problem? Why did I not succeed even connecting? And again, I like you to think about on your own what it could be. But I can tell you what I found over time. Number one, I was new in the community. That community didn't know me. I had no relationship other than the clinic I was practicing. Some of the nurses knew me, but not any neighbor, not any community person, or no community leader. So I had no real relationship. And I didn't think that was even needed at that time. Second thing is, I didn't know history. In community engagement, history is important. When you talk about racism, why history is important? Because that will come to bite you if you do not address that. The same thing, I didn't know the history of that community. They had a big university coming to that place at least 3 times before I came in, doing some research and leaving that community without giving anything in back in terms of even the result. So that was the history, which I didn't know. Third thing I didn't know was that was a tobacco producing county. And out of 10 minutes, I talked about 5 minutes on tobacco, quitting or reducing, and the evil of use of tobacco. So I like you to think about that community in many different ways didn't hear me. Plus, their daily living, their social determinants of health, their lack of financial, situations, or any other access to positive social determinants of health, housing, or homelessness, all of those compounded their health. So talking about cardiovascular disease, which was number 1, didn't make any difference to them. That was not the priority. And I learned it very hard. So anyway, after that, I started learning more about how to connect with community. That brought me about 30 years ago to a literature called CBPR, Community-Based Participatory Research. And I started learning more and more. The literature was full of responses coming from other part of the world, less from here. South America had lots of community engagement work. Even Asia and some Africa had it. American school had close to 0 or none at that time. So that started the whole process of learning, and I am going to tell you where we are because of understanding that you cannot make an impact on social determinants of health, health equity, disparity, unless you work with the community. So my first thing you have in front of you is the definition of community in here. The take home from this one is this. The critical aspect people always confuse about when they say community, they always connect with a geographical area. Or yes, it could be geographical, but it could be anything else. If you are doing a HIV program in 10 different states, your whole community could be connected to all those states and HIV program. Just an example. So this is one thing if I like you to go ahead and understand this piece, have it in your mind, how community is defined. If you didn't know, this is important to know. But one thing you have to also understand, it is not dry as you think, meaning that usually the community you're trying to work with, they have to understand, they have to have a shared emotional connection to the topic. So I said about HIV, so naturally, certain population will be very interested, or shared values and norms. Those are the other key factors that makes a community. So this is one. Next slide. So my first question in one word, I like you to think about what does community engagement means. What do you think? And we're going to tally it, and Sarah is helping on doing that. Take a few seconds to answer, please. Please feel free to answer. There's no wrong answers. Intentional collaboration. Listening is a very key principle of community engagement. Diversity, inclusion. I keep on reminding you, collaboration is critical. Intentionality is very important. You don't do it for unconsciously. You have to be conscious about your intention when you work with it. Caring, because this is the reason community engagement CBPR came, because people have worked with the community without really caring for them. All of you have heard about Tuskegee, and there are 100 different kind of Tuskegees we have in our country, where the researcher came and did research without really caring. Community engagement completely looks at the other way. Other way meaning that they like to have empathy, like to have a positive partnership, relationship. I keep on seeing the listening part. This is a very critical aspect. You have to know how to listen. You do not cook up your research idea sitting in your office or your building. That's what I did years ago. I had no idea that I'm supposed to listen. I was doing good, quote unquote, without knowing that nobody will come, even if I open the shop. That's what it is. Togetherness, culturally positive. Outreach is one part of community engagement. Humility. You cannot do community engagement if you don't have humility. This is a very different kind of research. It is not a typical kind of research you do. You have a betterment, interest to betterment, the community's health, community's future. Education is another part of community engagement. Building respect, building trust. If one thing you have to take it from today is this. If you do not know the trust is important in relationship with community, or you don't know how to do it, community engagement may not be for you. You may be a wonderful person, but that's not the point. The point is, those are critical pieces. Thanks, Sarah, or somebody else helping us putting the map together from the comments you made. And I'll tell you, you have captured many of those things wonderfully. Now let's look at the community engagement definition, what we have put in here. And we have underlined basically three things. I could underline everything. Collaboration, as you guys came many, many times. Yes, collaboration. People do collaboration without having the intent for doing a partnership, meaning that I can collaborate with A and B, but internally, I don't think they're my partner. That goes against community engagement. Another underlying point is reciprocity, which is completely opposite of many other research ideas. So there are many research people can do. You can do basic research or clinical research and others. There is no requirement that it has to be reciprocity. The community engagement, when you do the research with the community, with them, research, you think about how it will be reciprocal, how it can help on both sides. They are not just quote unquote subject. So you cannot do community engaged research if you take your community as subject. Those are the fundamental principles. And it has to be mutually beneficial. And that has to be not exchange of only knowledge, also resources. If you do community engagement, you got a grant and you got 100% of the grant funding, then you have a problem. Years ago, when I first came in, one of the faculty from a department came because he got a major grant from NIH. He came to talk to me in my office and he wanted 10 African American churches. I told him that I don't own any church, African American or otherwise. But the challenge is people think that, well, I have grant and let me get some people to work on it. That's not what community engagement is. That's not community engaged research. Next slide. Another question we have is, whatever level you are, whatever experience you have in community engagement, again, I would say that it could be different from different people. Some of people have already done some research. Some people have done volunteerism. Some people have done a little bit more than that. So this is a quick snapshot of all of you. And I just like to see what we get it from you. So I am already seeing that large number has some volunteerism in the community. You have to remember the volunteerism is actually one of the earliest steps, which usually brings you. That's the way I started my community engagement work many years ago, actually in Houston, before I even came to Ohio. I volunteered in some clinics, very poor, uninsured clinics, with one of my mentors attending that time. That was my foray into the community space. I see some of develop the partnership, absolutely. Research that involves the community and research not on the community, critical. Some people have done it. I also see communicate medical information. Now, this is the one I would most probably would not think too much about it, the number one, communicate. But I would say because of the COVID, one thing I learned even myself, we have a responsibility of being the source for information, scientific information, evidence-based information. Because you know that with the COVID, there are lots of misinformation that was going around. And I have talked to many of my patients and community partners. And I was astounded by some of the lack of clarity in terms of knowing what COVID is. So your job, our job, is also communicating and being an educator. And some of you have some other experience, but thank you. I think that was a great list of experience. Now I'd like to jump into rational. Why do community engagement? I gave you a little bit clue about it when I said that disparity and advanced health equity. That was not my idea. IOM in 2003, first time, they started challenging the concept that we have health disparity and we don't have enough health equity. How we address it? When I keep on saying social determinants of health affects 80% of your health, what is well and good, but how do you do anything about it? So their first report that was a long time ago said who will keep public healthy. They strongly emphasize public health to address connecting with, working with the community partners. You have to know, I have a background in public health. In the public health school, I got a single class on community engagement. Those are not even discussed or talked those days. But they emphasize IOM, that public health professional, that is broadly defined from the nursing to the medicine or anybody else. If you want to keep public healthy, you have to learn CBPR. That was actually their major push. CNR, community engaged research term, came many years later, if I have time to tell you, but they are very similar. But they keep on pushing for CBPR as the process, how you really do community engagement, how you make an impact on health disparity and advanced health equity. And the latest one you have on 2013, Institute of Medicine. They also, CTSA is a major program. I may not have time to tell you, but you guys are part of it. They emphasize community engagement as the key domain for everyone to push. If you really want to make research accessible, research actionable, research uptake is uniform among community partners. That was the 2013. Right now, actually, IOM has changed their name called National Academy of Medicine. And actually, I'm part of it. We are working on the next phase of community engagement called measurement and metrics. That will come maybe end of this year. So back to a few other points on the top, contextual factor I mentioned, but community also over time, they figured out that they have been fooled by academic partners for a long time. They didn't want to be a subject anymore. So lots of community organizations, and there are some names you may or may not know, started coming up that they don't want to be subject of research. And who listen to that? Few people listen to that. Foundation, like Robert T. Johnson Foundation, Kellogg Foundation, CDC, Center for Disease Control, had one of the earliest community engagement programs. In NIH, National Institute of Environmental Sciences, but not everybody got into this, should I say, the mindset that we need to respond to community partners. But we found over time the community distrust cannot be overcome because they have bad history with academic for a long time, unless you really talk to them, make them partners, use their knowledge as you are coming up with your research formulation at every stage. So that is what brings the relevancy of the data. So we don't think I can do a research in the community where community has zero input and they would think it is relevant. That doesn't happen. That is the reason many of the research was never taken up by any community group or community partners, even if it was well done by NIH standard. Next slide. Thank you. So principles of community engagement, I think I'm going to go a little bit fast. Looks like I'm a little bit behind. So if you look at the CBPR, community-based participative research literature, they have about a dozen principles. And then the CNR, community engaged research, has about 5 major principles. Actually, all those dozen principles, you can fit it into this five of them. So let me quickly go through that. Community program has to be well defined, but it is also a science. You don't just haphazard way come up with the program. Also, you have to know the scope of the program. Give you an example, we had program with the veterans about their alcohol program or substance use. Then we change it to, or expand it to opioid use. So that is the scope of the program. So if you change it, you have to be clear. Community partner has to be clear. What is the definition of that particular program and what does it fit in. Because community changes, many things have changes in your program. You have to assess that from time to time where you are. Strong community-academic partnership is the soul, because this is where the trust comes in. It sounds so simple, but I would say this is the difficult thing to do, having a great relationship. So I had program with the United Community Center for years. I had built that when it was no program. And somebody asked me, I didn't get any grant with the UCC for 4 or 5 years. How did I keep the relationship? I said, I built trust. How did I build trust? Well, I used to go there for their fantastic fajita and margarita. They have a cafe, and that was my every monthly visit. And I used to invite their leaders to medical college. So that is one. Equitable power and responsibility, it doesn't mean equal. Some places will contribute more than the community partners. Like in the research method, I may contribute more. In some other areas, implementation of a program, community may do that. But that still have to be equitable. Capacity building is critical. You have to capacity changes in the community. If community partners are working with you and they are exactly where they were many years ago, in terms of their capacity to understand their problem and do research, you have not served them well. Same thing about the academic partner. They need to grow with the development of program. And lastly, the dissemination, both peer dissemination and layperson dissemination is critical. And you have to work with them to do that. Next slide. Lastly, Medical College of Wisconsin, so that you know, we are actually very much nationally and internationally known. We are the first one who started the President's Community Engagement Award. Carnegie classification is the, I think, the benchmark for outstanding community engagement, nationally and internationally recognized. Our medical school is only one of the 4 medical schools ever to receive that classification. We received it in 2015. And AAMC, as a community service award, we received the whole award one time, and we are also top 3 a few years ago. So those are major achievements. 20 years ago, we had very little community engagement. So next slide. Right now, I don't have time to go through all of those. We have partners 650 and 430 faculty. About 19, 20 years ago, we had 3 faculty who even heard about community engagement or did any CBPR. And we had only 2 programs when I first came in many, many years ago. So if you look at it, there is significant change. So I feel very enthused when I see that we have made some progress. Next. Last, maybe, question for you guys, if you can answer. Knowledge, purposeful, solidarity, wonderful. Authenticity, that is another key word. You cannot be not authentic and do community engagement. Community will see through you if you are not really authentic. If you really, and it doesn't mean you're a good or bad person. If you're not interested in community's health, don't do community engagement. I always advise people. And again, communities, you don't need another person going there for ulterior reason or motive. Be authentic, have the value, have the insight, human interaction. Ultimately, I think you have to not only believe it, you have to role model it, your humanity, self-responsibility, teamwork, holistic inclusion. It has to be inclusive. You cannot, this is the critical. Empathy keeps on coming, care and value keeps on coming. So these are the few things I like you to self-examine, any one of you. So I have this thing, maybe I'll be good for community engagement and community engaged research. That will suit you well. I don't think I have time to do this part, but I will quickly tell you there are lots of steps how you start a community engagement program. You have to have the clarity of your purpose. You have to think about what is your platform. Is a small CBO versus a large local organization versus a national platform? What kind of impactful program you create? What kind of pathway, which is actually process, how you develop a program. It takes multiple steps. and then you laid out a plan. So again, it is a very quick response to what I'm trying to tell you, but I will stop there. Look like I'm going beyond my time. This is one of my favorite slides, so you can see it. And I do not know if you have any Q&A. I hope you guys stay a little longer, if you could. So Sarah, if you have any question, I can answer in 2 minutes. I'll do that.
Thank you, Dr. Ahmed. I wanted to let you know that we've been monitoring the Q&A and we don't see any questions at this time, so we let it go a little longer and the timing works out perfectly now to transition to the next speaker.
Thank you, Sarah. Thank you, everyone. Brian Johnston. Brian, I'd like you to take from there.
Excellent. Thank you, Dr. Ahmed, and thanks for that introduction. So I wanted to talk with you guys just briefly, kind of telling a story to illustrate some of the themes in how community engaged research can work out. I'd like to illustrate some of those core principles of community engagement through the lens of a program, a community engaged research program that I've been involved with for some time now. So briefly, this program is called the Food Doctors. Some of you present are aware and involved in this program. It actually started 9 years ago when I was a first-year medical student, as many of you recently were. I came into medical school with a background of community-based education programming, and so really had that mindset in when I came to medical school here. I also really wanted to create some sort of impactful program that would potentially live on in the community here even after I finished. And fortuitously, I met one of my roommates, Ahmed El-Arabi, who had a similar idea of wanting to try to build something that would create and leave an impact. He had a little bit of a different background. I am not very good at cooking, although my wife has been gradually teaching me over time, but he came in with, he's just like a magician with anything involving food, and he would spend all day in there and just, blow your mind with what he would create. So we kind of teamed up and thought that we wanted to do something in nutrition education. The first principle of community engagement that resonates with this story is that strong community academic partnership. So we were both new to town, didn't really know what the community very well. But the story of how this program really came about is kind of interesting. So Ahmed, as many of you have, took advantage of some of the MCW volunteer opportunities that you get recruited into frequently early on in first year of medical school. And he began volunteering at what became our really strong long-term partner, Milwaukee Academy of Science, which is a charter school on the north side of Milwaukee. And he started showing up there and working with kids in a mentoring program on a volunteer basis, helping kids with science projects and homework and things like that. He came to know the school and be known as someone who would kind of contribute selflessly and, to the community. And when he brought up the idea of something, doing some sort of project around nutrition, he was really met warmly by the school and connected quickly. And because he was known already as someone who was interested in contributing to the well-being of the school and students. Turns out the school felt there was a need as well. They didn't have any nutrition education as part of their curriculum. And so we kind of got together to create that partnership. And that partnership has now persisted for 9 years. I'm now the faculty advisor of the program. And even as the student leaders have turned over, we've been able to build like handoff protocols and techniques for allowing that partnership to continue. And actually having the medical student leaders sort of own that partnership has been like a really cool thing for them, a little bit different than signing up and showing up to a volunteer task every once in a while, that continued conversation. The next theme, which really follows from that one, is the equitable power and responsibility principle of community engaged research. there is sometimes a tendency once you have a project to kind of do the project and kind of stop some of that communication that you're having with the partner. And I think that especially when you get into the research phase, it was really important for us to continue that communication dialogue and make sure that we present ourselves as you know, wanting to make this the best possible experience for the school, and being mindful always of the impact on the community that we were working with, and making sure that their voice showed through both the third and fourth grade students that we were engaging, as well as the teachers and administrators, to really have power to shape the program. And that, you know, that type of equitable power and responsibility has been a key aspect of our model over the years. Those early discussions about what the program was going to look like, we knew we wanted to do something around nutrition education, but thinking about the next principle of community engagement helped shape our intervention. So that principle is defining the community and program scope. So in nutrition education, you could do so many different things, but working with our partners and understanding what their priorities were and what resources that they had, and what needs they had, in addition to looking at what the literature says about what is an appropriate and effective program, we decided to work on a few things. We focused on third graders and then eventually fourth graders. We decided to work within the school day schedule, and the school was gracious enough to support some curriculum space and physical space to do that. We found that MyPlate, which is a nutrition education tool, was already being used in the cafeteria, and so we took that and built the curriculum around MyPlate to continue that engagement. And within that larger framework, coming down to a more contained scope, that did limit what we could do and what impact we could look for and evaluate, but it allowed us to be really creative and really comprehensive within that scope. And that helped everyone to understand the project and make it a successful one. Within that effort, we were really seeking to build capacity, which is the next community engaged principle. So initially, the big focus we had was on developing medical student capacity. So medical students that go through this program develop cross-cultural health communication skills. They develop teaching skills, which teaching is really hard if you haven't done that before, and not totally obvious. They really develop those community engagement, relationship building and partnership development skills, and they develop scholarly skills too. So they really developed in the community engaged researcher skill set, which is a really powerful and impressive skill set to come out of medical school with. We actually looked at just submitted a manuscript looking at some of the downstream impacts that this program has on medical students. We also started thinking about what kind of capacity is being built within the elementary student participants. And something Dr. Ahmed said connected with me, thinking about community engagement as contributing to public health. And I think, you know, with the third and fourth grade students that we worked with in this class, one thing that we heard over and over from teachers and parents and the students themselves is that the conversation really continued, and that the students were really empowered to have conversations about nutrition and advocate for healthier foods in their diets in different stages. And that was really exciting to hear that. And recently we've as part of additional students, med students projects, we've begun working on engaging with parents and teachers to develop more capacity to contribute to nutrition education. The last principle of community engagement is an effective dissemination plan. I'm really glad that this project has evolved into the kind of a pathways project format where students can be involved in an ongoing longitudinal basis. Initially, we were thinking about making it like a student organization driven project, but the extra time and scope of pathways involvement allows students to really get past that exposure and skill development and just understanding the lay of the land stage and getting into more of those, here's some intervention ideas, here's some research questions. I understand where we're at in the field and where we're at in the community, but what about this? And here's something that could, has come out of conversations with community partners. And all graduates of the program have some scholarly outputs that contribute to their future career direction and their resume and everything, but also bring additional contributions to the community. And the last thing I'll say is just I think another thing Dr. Ahmed says is remembering to bring that focus and complete that loop with the community partners around what the research findings are. When the IRB goes through and you finish your study, you may, there's a tendency sometimes to lose touch with that, but completing that loop really validates the contributions of your community partners to your research projects and solidifies that community engaged research partnership, setting the stage for future work, which has been so fruitful in this partnership. So that's the food doctors, and I think right now we're going to kick it to Dr. Ruffalo, and she's going to share a story about one of her own community partnerships.
Yeah. Thank you, Dr. Johnson. Good afternoon, students. As Dr. Johnson mentioned, my name is Dr. Ruffalo, and before I share a little bit of my story, I just have to confess that when you all did the poll where you had to select one word that speaks to the strength of community engagement, I actually had chills. Some of the things, humility, teamwork, understanding, and I think that it's all well and good if you all can leave medical school being able to apply community engagement principles to research, but even better if you can apply them to being a physician. I think there's a lot of transferability of these concepts, and the ability just to understand the perspectives of others it's a universal part of being a good human being. And so that was just really exciting to see that so many of you are oriented that way. So the project I want to share a little bit about today is around a line of research around caregiver support. Before I dive into a little bit of a description, I just want to define some terms. So when I say caregiver, I am referring to an unpaid individual that provides support to a family member or a friend. I may also refer to an individual as a care recipient, which is exactly as it means. It's the patient or the family or member or friend that are receiving the care from the caregiver. So like Dr. Johnston's Food Doctors Project, this is also what we would consider to be a legacy project in regards to students. We've handed this project off to multiple students. Not quite the 9-year mark. We're going on our 4th summer of student engagement. So not a newbie anymore, but not quite as a decade-long partnership. The really great thing about our caregiver support, research, and community academic partnership is that we have lots of partners involved. Our first partner is Irb Senior Network, which is a nonprofit caregiving and care recipient support organization out in Waukesha. Our next partner is the Aging and Disability Resource Center of Waukesha County. Our third partner is Freighter Health. And then, of course, we have the Medical College of Wisconsin. We were actually formalized as a community academic partnership in about 2015, 2016. And what really makes, in my opinion, what makes us a good partnership is that we all bring these unique skills, experience, expertise, strengths to our team. Again, as was mentioned in the doodle poll, or not the doodle poll, but the poll, teamwork is pretty critical to this work. So from the lens of Irb Senior Network, they really bring that boots on the ground, nonprofit community voice to this work. They have a lot of experience with caregiver support, care recipient support. They have a robust volunteer workforce that we can tap into for our work. And they know resource navigation to support caregiver and care recipient dyads. With the Aging and Disability Resource Center, we have a public government sector involved in this work. And so their strengths and their expertise that they bring to our partnership is really around assessment. They know how to assess where the care recipient is as far as their ADLs and their IADLs. And I know many of you may not be familiar with that term yet, but when we speak to ADLs, we're thinking of activities of daily living. So can the care recipient feed themselves, bathe themselves, etc. IADLs being instrumental activities of daily living. Can they shop, housekeep, do their laundry, etc. The other thing that ADRC does really well is they have a mechanism, because they're a government-funded agency, they are able to do caregiver, care receiver competency assessment. So beyond just what the care recipient needs, what does that dyad need to really be effective in caring for that individual? And then with Freighter, our main partner with the Freighter Health System is pretty high up the food chain. She's actually the vice president of post-acute critical care for all Freighter Health. And so we have some power. We have a key decision maker at the table that's really influential in changing the way policies and procedures come into play in the health system. And then with the Medical College of Wisconsin, with my role and my team's role, we bring that research rigor and that research lens. And so the reason I highlight all of our partners in the skill set is just to show just the breadth that you can tap into with a community academic partnership to really, really impact change. And I noticed that was another word that was brought up in the poll is impact. And from a community health perspective, if that's what we're after, and it is, by having these multiple stakeholders at the table, we really increase our chances to really make measurable, significant, sustainable changes in our communities. So we came together again about 4 or 5 years ago now to really recognize that there's not enough intersection and cross-collaboration that's happening between health systems, government and public sector, and the nonprofit community-based organizations. And so what we did is we applied for a grant, like many community academic partnerships do. We were successful in launching a 4-year grant that's funded through the Advancing a Healthier Wisconsin Endowment. We're currently just at the start of year 2 of our 4-year grant. And really what we're focused on with that particular grant is thinking about right time support for caregiver, care receiver dyads, thinking about how each of these agencies and each of these sectors goes about identifying the care dyad, and technology systems and communication. How can we create agnostic systems where somebody at the ARIS Senior Network could communicate with somebody in the Freighter Health System? So that's really the snapshot of who we are as a partnership and what we all contribute. To kind of relate it and demonstrate how I feel we really represent the principles, I'm going to give a couple of little glimpses of that. So with the equitable power principle, one of the things that I think our partnership does really well is that when it comes to the institutional review board or any sort of budget considerations with our grant, we do not move forward on a single one of those elements until everybody in the partnership has bought into it or is aware of it. So everybody has a chance to review an IRB protocol before it's submitted to MCW, has a chance to weigh into it, has a chance to seek approval from any higher ups that they need to. So I think that's really gone a long way for our team to really build, again, a trusting, supportive environment. And then with the budget considerations, I think transparency and budget is really key to these community academic partnerships. The next principle I want to touch on is around capacity building, and really speaking from capacity building within ourselves. The thing that's so beautiful about community engaged research is that I think often I have been on the receiving end of getting more than I've given to the partnership. And I just feel like I've always left, not that I ever leave them, but you always come out of a partnership, I just feeling enriched and learning about something that I hadn't known about before. And so a good example of that is through the work with the Aging and Disability Resource Center. So again, this is a government funded, it's a public agency. I've learned so much about how that works, the pace at which it moves, how you get through red tape, some of the restrictions around it. It's just been really, really powerful. And I feel likewise, from a research lens, our other partners have learned so much about the research angle. We have a community partner from ARIS Senior Network who does qualitative data analysis with our team. She gets involved in the thematic coding of data. It's a really cool thing. The last thing I want to recognize real quick is around the principle of effective dissemination. And this is the principle where I feel our partnership shines the brightest. We disseminate together all the time. It is not unusual for me to attend a board meeting for ARIS Senior Network to give a new voice at the table. Everybody on that board is well aware of what the executive director's stance on caregiver support is, but to have a new voice there, somebody from the Medical College of Wisconsin coming in and say, yeah, this is where we should put some energy behind, has been just really effective in supporting the goals of our community partners. And likewise, when we do academic dissemination at the American Public Health Association, et cetera, we have had our community partners travel with us to those conferences. And I can promise you that when I'm presenting to an academic group, they are way more interested in what my community partner has to say than what I have to say. So I feel like we've really cultivated a really supportive partnership that really recognizes the power and the expertise that each of us can bring to our partnership.